Thank you very much, and good morning. It's a real privilege to be here talking about what I consider to be the most interesting topic in internal medicine, which is acute kidney injury, and hopefully you'll see why. I have no relevant disclosures today. So the goals for the next 25 or so minutes are as follows. I'll introduce you to the terminology we use for acute kidney injury, its definition, review a bit on the epidemiology of AKI, its incidence, mortality, and costs associated with AKI, and then provide you an approach for dealing with the patient with acute kidney injury, and then focus on a few specific clinical scenarios. So let's start with a case. This is a 64-year-old gentleman with hypertension, diabetes, osteoarthritis, and BPH. He presents to the emergency department complaining of nausea and vomiting. His medications were lisinopril, metformin, ibuprofen. On exam, his blood pressure was 100/60, heart rate was 104, respirations 16. Physical examination was relatively unremarkable. His lungs were clear. His cardiovascular exam was normal. He had a soft abdomen and no edema on his lower extremities. His laboratories, however, are quite abnormal. He had hyperkalemia to 5.6, serum bicarbonate of 18, BUN of 84, and a serum creatinine of 3.2 or 283 micromoles per liter. So this gentleman has abnormal kidney function, and he may have acute kidney injury. For those of you who trained before the 1990s, we called this acute renal failure, and then over the last 10 plus years, we've had a change in the terminology to acute kidney injury. And we'll review each of these terms in turn. So acute, of course, means that the condition is happening within hours to days. Kidney was replaced for renal, just because I think it's more familiar sounding. But the real big change in the definition or the terminology was the substitution of the term injury for failure. And that's in recognition of the fact that not all individuals with abnormal GFR or an increase in creatinine have failing kidneys. They could have simply injured kidneys. And it focuses the disease more on organ damage as opposed to functional derangements. So the definition of acute kidney injury it has been quite variable historically. If you look through the earlier literature describing acute kidney injury in hospitalized and non-hospitalized individuals, it's all over the map. There are some definitions that used 50% increases in creatinine, stratified increases, absolute increases based on the baseline, sudden rise of greater than 2 milligrams per deciliter. So there's been a multiplicity of definitions, and that's been a major problem for our field because conducting epidemiology studies, conducting clinical trials was made difficult by the absence of a uniform definition. And there's over 30 definitions that have been used until the last several years, and this is the most recent consensus definition of acute kidney injury by a group of investigators and clinicians called the Kidney Disease International Global Outcomes, or Improving Global Outcomes Consortium. So the definition of acute kidney injury is now an increase in serum creatinine of greater than or equal to 0.3 milligrams per deciliter, or 26.5 micromoles per liter, in 48 hours, or a 50% rise over baseline in 7 days, or, and this is a bit controversial, the presence of oliguria of less than 0.5 milliliters per kilogram per hour for at least 6 hours. So this is a definition that has now been used, if not so much in the clinic or in the hospital, in research. Many trials are using this definition as inclusion criteria or exclusion criteria or endpoints. Clinically, it's not caught on so much, especially this 0.3 rise within 48 hours, which is a pretty small change in kidney function. So that's the new consensus definition, could very well appear on the boards. The reason for actually incorporating that 0.3 threshold are these data that date back from 2005, generated by my friend and colleague Glenn Chertow at Brigham and Women's Hospital when he was here. What he showed, and this is a graph from a paper showing the odds of death on the y-axis, and it goes from 0 to 90. So this is a huge increases in risk of death that they're showing, and they're showing that relatively modest increases in creatinine, 0.3 milligrams per deciliter, were still associated with an increased risk of death. Of course, the major risk of death is seen in those with substantial rises in serum creatinine. That's not surprising. But the fact that small changes in creatinine, so 0.3 milligram per deciliter rise, was still associated with a 70% increased odds of death, that really prompted this new definition, incorporating smaller changes. Acute kidney injury is also increasingly common, and not just because of the changing definition. We examined this, and others have examined this in time series studies, showing that there's been an almost fourfold increased risk of acute kidney injury over the last 20 years. A community-based estimate of incidence of acute kidney injury suggests that it's about as common as stroke, 520 cases per 100,000 population. So acute kidney injury is increasingly common over time, probably coinciding with the increased prevalence of chronic kidney disease, more aggressive use of interventional procedures, cardiac procedures, and imaging with CT contrast agents. Acute kidney injury is also expensive to our healthcare system. It's been estimated that the cost of medical care of an individual with acute kidney injury after cardiac surgery increases by 60%, and $5,000 when creatinine increases by just a small amount. These are, of course, modeling studies, but the idea is that preventing acute kidney injury would result in substantial cost savings to the medical community and governments, about $10 billion annually. So that's the epidemiology of acute kidney injury. I'll now switch to the approach, the clinical approach to the patient with acute kidney injury. So we approach it in some anatomical sense. So I'm going to first give you a brief overview of the anatomy. This is the gross anatomy, the anatomy of the kidney and ureters and bladder. This is the micro anatomy, which I'll review in a little bit more detail when talking about specific causes of acute kidney injury. So we approach it anatomically in the sense that we divide it, and this is a time-honored approach to acute kidney injury, into pre-renal, post-renal, and intrinsic causes of acute kidney injury. So post-renal we'll start with. It's the one that you should really strive to rule out initially because it's quite treatable. So post-renal acute kidney injury occurs when there is an obstruction to flow of urine anywhere along its course, either very proximally with stones or blood clots, retroperitoneal fibrosis along the ureters, or even very distally with bladder outlet obstruction, obstructed Foley's, urethral obstruction. The approach to ruling out post-renal, of course, is to first check a bladder scan, insert a Foley catheter. But imaging is the mainstay of diagnosis, either renal ultrasound or CT imaging, or of course MR if it has already been obtained. A couple of pearls on the diagnosis of post-renal kidney failure. Early in obstruction, there may be no radiographic evidence of hydronephrosis. The kidneys and ureters have not had time to increase in size. The other very important setting in which there can be a false negative, so no radiographic evidence of obstruction, is in the setting of retroperitoneal fibrosis or in tumors with bulky retroperitoneal adenopathy. In those conditions, again, there is a mechanical obstruction that basically does not allow the kidneys or the ureters to show evidence of increase in size. The diagnosis in those conditions has to be pursued with a retrograde pyelogram, or sometimes even just going straight to interventional procedures, ureteral stenting or percutaneous nephrostomy tubes, if the pretest probability or suspicion is quite high. So that's post-renal obstruction, important to rule out. Pre-renal, on the other side, is when the kidney function worsens due to renal hypoperfusion. There's thought to be no actual structural injury to the kidney, and there's generally recovery of kidney function once hemodynamics are restored. The causes of pre-renal azotemia include the following. You can be hypovolemic, there can be decreased cardiac output, or there can be decreased effective circulating volume in the setting of congestive heart failure or cardiorenal syndrome or cirrhosis. And then there can be impaired intrarenal hemodynamics, and this can be drug-induced. And it's worth pausing to review a little bit about the intrarenal hemodynamics and response to hypovolemia. So when there's hypovolemia, the kidney senses it and through a remarkable series of adaptations maintains GFR. And it does this by maintaining the intraglomerular pressure by increasing the vasodilation on the afferent side, and this is prostaglandin mediated, so the afferent arteriole dilates, so there's an increased blood flow, or the efferent arteriole constricts, and when there's efferent arteriolar constriction, the perfusion pressure or the hydrostatic pressure within the glomeruli increases. And those two compensatory mechanisms work hand in hand to maintain GFR. And the efferent vasoconstriction is angiotensin II mediated. The afferent vasodilation is prostaglandin mediated. And in prolonged hypovolemia, this can be overwhelmed, and you can develop acute kidney injury or pre-renal azotemia. So NSAIDs, the reason that individuals with NSAIDs are prone to developing pre-renal AKI is that this afferent vasodilation that's prostaglandin mediated is interfered with. So the NSAIDs work on the afferent side of the glomerulus, and ACE inhibitors and angiotensin receptor blockers mostly on the efferent side. So this angiotensin II mediated efferent vasoconstriction is impaired. You can imagine if you're on both NSAIDs as well as ACE inhibitors or angiotensin receptor blockers, your kidney is extremely vulnerable to pre-renal azotemia or hypovolemic AKI. All NSAIDs, including COX-2 inhibitors, can do this, and ACE inhibitors as well as angiotensin receptor blockers can cause pre-renal azotemia. Not much difference across medications. So that's pre-renal AKI. So now we'll go into intrarenal causes of acute kidney injury, and I'll just review the anatomy real quick. This is the glomerulus, so this is the afferent arteriole that we saw, the efferent arteriole, Bowman's space, and then the proximal followed by the distal tubules and the collecting duct. And so we can approach intrinsic causes of acute kidney injury with a similar anatomical approach by dividing different cases of acute kidney injury into its various compartments. So there can be tubular injury, so acute tubular necrosis can be seen in the setting of ischemia or sepsis or toxin-mediated, for example, rhabdomyolysis or hemolysis. Exogenous toxins from drugs such as contrast media, cisplatin, and gentamicin that can all cause tubular injury, and this is a cross-section of the tubulointerstitium. And if there's injury here within the tubules, there can be obstruction of the tubular lumen and a back increase in pressure that limits glomerular ultrafiltration. Similarly, there can be intratubular obstruction, so in the setting of myeloma proteins that can crystallize, uric acid crystals that can form in hyperuricemia. Tubular injury itself can cause the tubular cells to clog up the tubular lumen. And then certain drugs like acyclovir and methotrexate can also precipitate within the intratubular lumen. Then there's the interstitium of the kidney. So this is the connective tissue that's a big constituent of the renal parenchyma and a very important constituent. When it gets inflamed, when there's interstitial nephritis, there can be acute kidney injury, and that can be in the setting of allergic diseases or allergic reactions to medications, so penicillins or rifampin. There are certain infections that can also cause acute interstitial nephritis. Severe pyelo is unusual as a main cause of AKI in and of itself without hypotension, but severe pyelonephritis can cause inflammation in the parenchyma. And then Legionella, as well as severe sepsis, is thought to cause an interstitial nephritis. There can also be infiltration of inflammatory cells into the parenchyma, so in lymphoma or leukemia. And then certain inflammatory conditions of the kidney that cause interstitial inflammation include Sjogren's disease, tubulointerstitial nephritis with uveitis, relatively uncommon, and again, sepsis. And so that's the tubulointerstitial compartment, a very important cause of acute kidney injury. And then the smaller blood vessels in the kidney can also become inflamed or injured. And this is here again in the glomerular capillaries, also the smaller peritubular capillaries. So glomerulonephritis, vasculitis, TTP-HUS, disseminated intravascular coagulation, atheromembolic disease, when there's cholesterol plaque that can get into this afferent arteriole and cause hypoperfusion. Severe hypertension and sepsis all can cause injury to the vasculature. Then the larger vessels can also be involved in acute kidney injury, so renal artery emboli, or dissection, or vasculitis. Bilateral renal vein thrombosis can cause acute kidney injury. And then finally, abdominal compartment syndrome can cause AKI, probably through both compression of the vessels as well as compression of the tubules. So acute kidney injury can also be thought of sort of as, what is the pretest probability based on the clinical setting? So what are the common causes of acute kidney injury based on the clinical context? In the outpatient setting, important causes include pre-renal azotemia. Think about individuals who are on ACE inhibitors or angiotensin receptor blockers who then become ill, have the flu, hypovolemia. Their efferent vasoconstriction can be impaired. So that's a very common clinical setting when someone has an illness, as well as concomitant use of an ACE inhibitor, particularly if that's also with an NSAID at the same time. Another outpatient cause of acute kidney injury to be vigilant about is obstruction in an older individual, male with BPH, or someone with a history of kidney stones. You should have a high suspicion for obstructive causes of acute kidney injury. In the inpatient setting, it depends on the further clinical context. In the medical ICU, ATN from sepsis and drugs is a major cause. The cardiac floor, contrast administration, cardiac surgery itself can cause a lot of inflammatory changes, as well as hypotension that lead to AKI. Severe cardiorenal syndrome can cause acute kidney injury. And then in the surgical intensive care unit, rhabdomyolysis, sepsis, postoperative ATN. The acute kidney injury internationally, particularly in the developing world, has quite a different epidemiology. In sub-Saharan Africa, probably diarrhea has got to be the #1 cause of acute kidney injury around the world, but also conditions like malaria. In severe malaria, falciparum in particular, there can be intravascular hemolysis, and I showed you that graph of causes of acute kidney injury. Hemolysis can cause pigment-induced injury to the tubules, leading to acute kidney injury. In the tropics, conditions like leptospirosis should be kept in mind for AKI. And then other miscellaneous conditions, post-streptococcal GN is an increasingly common cause of acute kidney injury. And then in disaster areas, crush syndrome after severe earthquakes, for example. So the diagnostic approach, the first steps, now going back to this individual, remember this was a 64-year-old man who had both hypertension and diabetes. He was in the emergency department with nausea and vomiting. And remember his medications, he had the 2 meds that I have been sort of trying to impress upon you as major precipitors of pre-renal azotemia. He's on both an ACE inhibitor as well as an NSAID. He's on metformin. His exam is notable for just a little bit of mild hypotension perhaps, and pretty severe acute kidney injury. But is it acute? So the first question to ask is this acute kidney injury or is this actually just chronic kidney disease? That's easy if you have a baseline serum creatinine available. But if you don't, there are certain clinical clues to the diagnosis of acute versus chronic kidney disease. So the clinical context, of course, but there are certain laboratory findings and imaging findings. If there's long-standing anemia, it's a very non-specific sign, but it can be a clue to the presence of AKI or CKD, but certainly not diagnostic. The one that can be really helpful is the presence of small kidneys on renal ultrasound. If the kidneys are less than 8 centimeters, or if there's increased echogenicity by the report, that can oftentimes be a clue of chronic kidney disease. However, increased echogenicity can be seen in many causes of acute kidney injury as well, particularly in the setting of interstitial nephritis. So this is not at all to be construed as a specific sign of CKD. And the other thing is that there can be AKI on CKD. It's one of the major, probably the dominant risk factor for acute kidney injury is pre-existing chronic kidney disease. So someone could have small kidneys, CKD, as well as a new bump in creatinine. The second question is to risk stratify. How urgent is this case of severe acute kidney injury? The things that get us on the renal consult service awake at night is, of course, hyperkalemia, particularly if the potassium is greater than 6 or if it's rising fast. The most important vital sign that I try to impress upon my fellows in the patient with acute kidney injury is urine output. Anuric acute kidney injury is a completely different beast in terms of how much attention we'll pay to it compared to preserved urine output. Anuric AKI are the patients, if there's a decreasing urine output less than 500 mils per day, where we can really anticipate that if this does not get better, you're going to have problems with volume overload, hyperkalemia. So the urine output at the time of diagnosis is extremely important. Of course, severe hypoxemic respiratory increases the risk of complications in someone who's got acute kidney injury because of volume derangements. And then if there's any suspicion for an intoxication, methanol or ethylene glycol, salicylate ingestion, or lithium overdose, then that's another urgent call to the nephrology colleague because of the possibility of intervening with dialysis. So the physical examination in the individual with acute kidney injury is relatively nonspecific in most cases. Pre-renal AKI, signs of volume depletion, so orthostatic hypotension, tachycardia, decreased skin turgor. Hepatorenal syndrome can be suspected or should be suspected when there's stigmata of liver disease. Cardiorenal syndrome, of course, if there's signs of heart failure. The diagnosis of post-renal AKI is a radiologic diagnosis, but occasionally there can be a palpable bladder. One point to really keep in mind is that a normal urine output does not rule out the presence of obstructive uropathy, and especially as just a contributor to the AKI. You don't have to be completely anuric for your creatinine to start increasing in the setting of obstruction. And the reason for that is to consider the urine output compared to the glomerular filtration rate. So your urine output is about 100 milliliters per hour. Your GFR is about 100 mils per minute, right? So it's about 6,000 mils per hour. So most of the water and salt that's getting into our kidneys is actually being reabsorbed. So you can have a very substantial decrease in the GFR without really impacting your urinary flow rate greatly. So just remember, a normal urine output does not rule out post-renal obstruction. Intrinsic causes of acute kidney injury really depend on the type. Acute tubular necrosis does not have any specific physical exam findings other than volume overload if it's present. Glomerulonephritis you can have stigmata of GN depending on the underlying cause. Vasculitis can present with palpable purpura. Atheroembolic disease, so this is AKI after a cardiac procedure or imaging with contrast where the aorta is manipulated. In atheroembolic disease, you can see livedo reticularis, occasionally blue toes. Interstitial nephritis, acute interstitial nephritis, we're taught that there's a rash and fever that accompanies acute kidney injury and eosinophilia. Just remember that that's a relatively uncommon constellation of findings, that you can have acute interstitial nephritis without fever, without eosinophilia, without rash. And only 10% of cases have this classic presentation. So the studies to get in the individual with acute kidney injury, the Chem 7, BUN, creatinine, calcium are generally obtained. Phosphorus can be important. Uric acid as a clue to tumor lysis syndrome. CPK as a clue to rhabdomyolysis. The CBC with differential for interstitial nephritis. So if you see eosinophilia, that does increase your suspicion for AIN. Renal ultrasound or CT scan should be obtained in most cases of unexplained acute kidney injury. And then the urinalysis and urine sediment. And we'll make a couple of comments on the fractional excretion of sodium. So we're taught about this entity, the FeNA, or the fractional excretion of sodium in the differential diagnosis of AKI. And you'll remember it's the urine sodium, it's the serum sodium, it's the urine creatinine and the serum creatinine that are put together in a formula that spits out a FeNA, or fractional excretion of sodium. And the threshold that you were probably taught in medical school is 1%. If the FeNA is less than 1%, that's pre-renal azotemia. If it's greater than 1 or 2%, that's consistent with acute tubular necrosis. That can be helpful, but remember that you can have many exceptions to this rule. You can have acute kidney injury from acute tubular necrosis with a low FeNA, and that can be seen in contrast nephropathy, rhabdomyolysis, early in sepsis, in obstruction, and in acute GN. So the low fractional excretion of sodium that you were taught was synonymous with pre-renal azotemia is actually not. There's so many exceptions to the rule that we shouldn't allow it to confuse our diagnostic approach. You can also be pre-renal with a high fractional excretion of sodium. So individuals who are on a loop diuretic, who have sodium spilling into the urine. Individuals with pre-existing CKD are also operating at a higher fractional excretion of sodium to begin with, so you can have a higher FeNA with pre-renal azotemia. So back to this case of our individual with an elevated creatinine in the context of ACE inhibitor use, NSAID use, and a potassium of 5.6. So we obtained baseline labs. His creatinine was 1.0, so this is acute kidney injury and not chronic kidney disease. In terms of risk stratifying this individual, I would say it's not a complete emergency, but definitely urgent. He's got pretty significant AKI. This would be called stage 3 acute kidney injury because it's more than a tripling of his serum creatinine. He's got a potassium that's abnormal, 5.6, so definitely an urgent case of acute kidney injury. The immediate considerations that should come to mind are the following. So pre-renal azotemia because of his use of NSAID as well as ACE inhibitor. He's got a history of BPH, so you should suspect obstruction. And remember to stop the metformin in this individual. He's got also an emerging gap acidosis. So what to do with this patient? I would first start with a volume challenge. You would discontinue the ACE inhibitor, the NSAID, and then you do further evaluation of the AKI. Imaging to rule out obstruction, laboratory tests to start developing a differential diagnosis. One other point about acute kidney injury that we've begun to learn over the past few years with epidemiology studies is that a case of AKI, like a severe AKI, even if it resolves, years later can predispose to chronic kidney disease. So we've actually started to try to get follow-up of individuals with severe AKI in the renal clinic, particularly if they've had a case of dialysis requiring acute kidney injury. Those patients who have severe AKI that require dialysis have sustained parenchymal injury that can actually lead to chronic scarring that sometimes takes years to manifest. Further evaluation of intrinsic AKI, if you think that the patient's not pre-renal, you've ruled out post-renal, and you have no real reason to suspect acute tubular necrosis, so there's no sepsis, it's not post-op, there's no nephrotoxin exposure, et cetera, what are the labs that you should get to round out the differential diagnosis? Here's a partial list. We get complement levels, which can be low in diffuse glomerulonephritis, particularly in SLE. ANCA and anti-GBM testing can be quite important in unexplained acute kidney injury from ANCA vasculitis or anti-Goodpasture's or anti-GBM disease. And the diagnosis is important because initiation of treatment can preserve kidney function if started early. ANA for lupus, we get LDH and haptoglobin to look into potential causes of pigment nephropathy from hemolysis, for example, or thrombotic microangiopathy. And then kidney biopsy, I think, is ultimately the gold standard for diagnosis. We don't oftentimes do it, but there's an increasing appreciation for the role of kidney biopsy in the setting of unexplained AKI. A couple of patterns of creatinine elevation you should be familiar with. Pre-renal azotemia is when the creatinine increases and then goes back to baseline on its own with a correction of the underlying cause. If there's a rapid rise in creatinine, if the creatinine is increasing by 1 to 2 milligrams per deciliter per day, that can be seen in rhabdomyolysis. It's mostly anecdotal, and it's not related probably to skeletal muscle injury with release of creatinine from the muscle, but clinically we see individuals with rhabdo having a relatively rapid rise in their creatinine. If the creatinine rises within 24 hours, peaks within 3 to 5 days, and then returns to baseline in a week, that's a classic pattern for contrast nephropathy. And contrast nephropathy can typically be non-oliguric. Aminoglycoside antibiotics, which we're using less of, but if you have acute kidney injury in that setting, it can be slow to develop. The creatinine can rise after several days of treatment. The return to baseline, even after discontinuing antibiotics, can also be slow and sometimes not even complete. And individuals with aminoglycoside-induced ATN can be non-oliguric as well. So the major complications of AKI, volume overload, hyperkalemia, metabolic acidosis, which can be both a GAP acidosis as well as a non-GAP acidosis. Severe AKI can present with hypocalcemia, hyperphosphatemia, and then bleeding from uremic platelets, relatively rare, but in severe AKI with extremely high BUNs, you can develop uremic platelets as well as uremic pericarditis. And I mentioned the long-term risk of CKD as well as ESRD after AKI. Prevention of AKI is important. We avoid nephrotoxins. We maintain adequate intravascular volume. There's no evidence for prevention of AKI with N-acetylcysteine based on a large trial recently published in the New England Journal. Really no great evidence for bicarbonate in intravenous fluids. This story keeps changing with the publication of large ICU trials. No benefit for bicarbonate IV fluids in contrast nephropathy, but conflicting data, emerging data, and septic shock that it may be beneficial, particularly in the setting of CKD. We use furosemide to convert oliguric to non-oliguric AKI. But randomized controlled trials have not shown much of a benefit, so we don't use it specifically for treatment, although we do use it to prevent complications. And then treating AKI, improving hemodynamics for pre-renal, relieving obstruction for post-renal. There's no therapy known yet for acute tubular necrosis, particularly dopamine has been used a lot. Really no benefit, and there's actually potential for harm with dopamine for AKI. Interstitial nephritis is treated by withdrawing the drug if it's drug-induced, sometimes steroids. There's conflicting evidence on the use of steroids, but most people will use it for severe acute interstitial nephritis. Acute GN is treated with immunosuppression. It depends on the type. And remember, for scleroderma, renal crisis, this may come up on the boards, you actually use ACE inhibitors because of this extremely high renin-angiotensin state in scleroderma. So ACE inhibitors in the setting of AKI from scleroderma. Dialysis for AKI, remember AEIOU for indication, so acidosis, electrolytes, potassium, ingestions, overload, and uremia. So a couple of take-home points. Acute kidney injury is common, often deadly. We approach it anatomically with pre-renal, intrinsic renal, and post-renal causes. The indications for dialysis are the vowels of the alphabet, A-E-I-O-U. Remember the patterns of creatinine elevation. They're very distinct for pre-renal versus contrast versus rhabdo and versus aminoglycosides. And remember that the fractional excretion of sodium has a lot of exceptions. So let me go over a couple cases, or should we move on? We'll move on. All right, well, thank you very much for your time, and enjoy the rest of the week.